Hello, are you there?
Hey, good morning.
How are you?
I'm good. How are you?
I'm good. I'm getting this slide to where this the one that I want. So hang on just a second here. Here we go. So how's your day going?
It's going. How about you?
Yeah, it's going pretty good. The internet seems to be pretty slow, but
Yeah, I think that's everywhere.
yeah,
Holidays. Guess everybody's doing everything.
yeah. Oh yeah, the traffic was crazy. All right, well, it's nice to
You're in Chicago?
I'm actually near St. Louis. I'm in what's called
Oh,
East
you're closer to
Alton.
St.
Yeah,
Louis.
so I'm just 23 miles from St. Louis. But I don't see your picture. Are you doing that because you want to?
Oh, did you need to see me?
No, not necessarily. I just
Okay.
wanted you to know that I can't. But anyway,
Oh,
so
okay.
we'll go ahead and start if that's all right with you.
That is fine with me.
All right. So what I'm going to start with first is a perfect example of how nursing and any allied health branch of the medical profession is still not in the STEM world. They're not in the 21st century yet. And so I always start with the nursing example of the instruction they gave us for the mastectomy, axillary lymphadenectomy patient of don't touch that arm. No IVs, no BPs, and no blood draws. Well,
Right.
that's an incorrect statement, believe it or not. What they should have said was no tourniquet, no BP cuff, because it's a tool problem. So I'm going to start with that.
Okay.
There's the instructions. Don't perform any of those procedures. Now,
Right.
what is it that they all have in common? It's that the tourniquet and the blood pressure cuff cause swelling. And that's what the lymph nodes do. They get rid of swelling. They also fight infection, but swelling is the problem here. And it's all based on a fellow by the name of Starling. In
Hmm.
1896, he described the venous system, and venous pressures and venous blood flow. So this is all built on his information, not on mine. So what happens is the split second the tourniquet goes on, that vein, which you can see on your screen there, the normal wall thickness. And by the way, vein wall thickness varies throughout the body, but we're going to be thinking in terms of this antecubital vein. It's a certain amount of thick. And shortly, I'm going to tell you what that is. But as the tourniquet goes on and that vein starts to distend, the wall starts to thin. And at a certain point, that entire venous system starts to leak. And that leakage is called an infiltrate. It's also called edema, lymphedema, extravasation, transudation, but the other medical word is infiltrate. Now, go ahead.
Oh, no, go ahead.
And you don't have to take any notes, by the way. I'm going to send all of this to you. So what happens is the the system, as you can see on this one now, it doesn't leak just at the vein, but the venule, which is a small vein with the thinner wall, and the venous part of the capillary bed that we know is just membrane thin, tissue thin. So there's profuse leakage there. So that's the problem with the tourniquet and the blood pressure cuff. They cause swelling. Well, it's not just swelling that's a problem for the mastectomy lymphadenectomy patient. That infiltration is a problem for every patient. So we're going to come to that.
Mm.
So let's go back to the beginning. Do I hear a little dog?
You do. I have two dogs.
That's sweet. I'm a critter crazy person. All right, so everything that I'm going to talk to you today then is about the science, the STEM, science, technology, engineering, and math. And these guys here on the right are all the scientists that I pulled information from. And you can see they're all very old. So it's old science, just nobody ever applied it. So I'm going to teach you today, it's going to be how to locate, dilate, and grade veins. But those are the components that the VAT method consists of. So since we can't use a tourniquet to force that over distension so we can find that vein easier, we're going to use a totally different method. We're going to use gentle touch. So the index finger, the pad of it, gentle touch to locate, and gentle touch on the needle system when it comes time for that needle insertion. So there are the two pictures. There's our palpation technique and then the gentle insertion technique, which we'll talk about in another little presentation. So this gentle palpation technique is going to locate, dilate, and grade veins for us. And we locate first, then we dilate. Because right now, everybody's doing it the opposite. They're trying to, quote, dilate a vein with that tourniquet so they can locate it. And we just talked about the problems that the tourniquet causes. So with this gentle touch, we can get rid of that mean tourniquet and that rubber hose and a thump. Because really, we're going to gentle, gentle, gentle. The rubber hose and a thump, the old method, causes all these complications, compromises, injuries, and failures. And nowhere in the practice of nursing, radiology, laboratory medicine, or even medicine has anybody compiled these and put them all in one spot. And that's because nursing sees their venipuncture as a different procedure than the blood draw people see their procedure, and different than radiology sees theirs, when they're all the same procedure.
That's stupid.
I'm sorry?
I said, that's stupid.
I know, but they're just so disconnected. We think the doctors are disconnected from nurses, which they are, but the professions, the disciplines within it are just totally disconnected. So what is this new method? I call it the 21st century vein access technique. And now I'm going to teach you about it. So the current venipuncture methods cause problems. And the current methods of looking for a vein, they look, they smack, they want to use a vein diagram as a map overlay for where those veins should be located. Well, only 50% of the humans have that exact anatomy. The other 50%, it's a variation of. They're using a tourniquet, they're using an ultrasound machine or a vein finder tool. And we know so far, none of this has worked because it produces all those CCIFs. And in the profession, the scope, magnitude, and gravity of this is 5.5 million healthcare workers, and that includes x-ray techs, RNs, LPNs, medical assistants, paramedics, etc., phlebotomists, are performing venipuncture this old method. And 3.3 billion venipunctures occur each year. And out of that, those CCIFs are occurring more than 70% of the time. So it's a huge problem and we need to fix it. And so how do we fix it? We're going to use the VAT method. So first thing that I want to tell you is all venipuncture was built on the phlebotomy foundation, all of it. And the word phlebotomy, otomy, means surgery. And in fact, when the needle came to replace the barber's razor and the surgeon's scalpel, they kept the word phlebotomy. Why? Who knows? Because we don't cut a blood vessel with a scalpel or a razor anymore. But that wasn't the only thing they kept. One of the other things was that tourniquet. And just real quick, phlebotomy, bloodletting, used a tourniquet to prevent bleeding to death. The true use of the tourniquet. But for us, there's no longer a risk of bleeding to death. That tourniquet should have been put away. So here we go, and that was the story. In 1853, the barber's razor, the surgeon's scalpel was put away, but not much else changed. So those are the three eras. Bloodletting, and then second era was they kept the tourniquet and they did advance with the needles and the vacutainer systems, but we needed more improvement than that. So this third era is all about science. By the way, bloodletting, there was no science, literally. In the 18th and 19th century, those scientists that I showed you started discovering their science. But when the needle was invented, and this next era, the one you're currently in, came into being, nobody took the science and applied it. Well, that's all that I did. So I'm not a genius, but I did just take the existing science and I applied it. And that's where we're at. Vein access technologies applied the science. So after I just told you that part, now let's look at how that works. So I'm going to show you now some of the STEM information that I did apply, and we're going to use Gray's Anatomy and Guyton Hall's textbook of medical physiology. So the very first thing we have to consider is the patient's position of their arm. Now, I don't know how prevalent your veins are in your arm, but when you're with an arm with a bend in it, the vein is at its fullest. But if you straighten the arm, it flattens the vein because the tissue behind pushed it up against the anterior wall of the arm, right? The anterior surface. Now think about that when you're trying to suck blood out of that vein with your vacutainer system. If your bubble is facing up and your vein is flat, how many times have you started to get blood and then it stopped? And you thought, well, what happened to the vein? Nothing happened to it. And a lot of phlebotomists will lean down and onto that needle, which forces the posterior wall of the vein down, and then some blood comes traveling in, and then they get more out. But the reality is, to feel for these veins, that arm must be in that 130-degree position for those veins to be at their fullest. In the wrist can't be stretched over the edge of a table. It must be in the handshake position for the veins to be at their fullest. Okay, next. Again, we're going to use gentle touch. So to avoid all the mistakes that they're making, you're going to use the pad of your dominant hand index finger. And that's because our brain is wired to that dominant index finger for sensitivity, specificity, and accuracy. But it's the pad, not the tip. So using the tip at all, that means you're poking, and that's an insult to the vein, and that's going to be a problem. But the pad is not only gentle, but it's also getting rebound information it feels. So on this table, I have a long, skinny water balloon, and that is identical to what the vein, how it's built and what it feels like. Have you had that perception when you're feeling for veins? Feels like a water balloon bounce?
Yeah, a little bit. It
Okay.
depends. Some veins don't feel that bouncy.
Well, no, yeah, when you get tuned into this, every vein, every true vein you're going to access is going to feel like a water balloon bounce. If there's any other feeling other than that, you're not in a vein. You're over a tendon, or we'll talk about what else, but it's not the vein. So using the pad, and then you're going to feel that the finger must stay in constant contact. Excuse the vein up here, with the surface as you're doing it. In other words, you cannot lift off. It must stay in constant contact because it's the rebound information that we're actually ascertaining. And this vein, this water balloon, feels identical to a human vein. So when you palpate, and you would glide from medial side of the antecubital region to the lateral at the antecubital line, okay? If you're palpating dry, and worse yet with a rubber glove, but you can try with both. But either one, both create friction, and that's the grab and the drag that you'll feel. Even sometimes when the skin is really dry, theirs and yours, it might glide, but you still aren't going to feel that vein as well as this next part I'm going to teach you. The palpating dry creates friction. Well, friction by physics definition is noise to the brain. So you don't have a clear touch signal, you have a noisy one. And equate friction to the static on the car radio if the song's not tuned in. Brain goes, tune it in or turn it off, because it's audio noise. And I don't know how old you are, don't want to know. But the old days with the TV before satellite, there was all that snow on the TV. Well, that was friction. And it wasn't much fun to watch.
When we had antennas and bunny
Antennas,
ears.
yes. And it was hard to watch. No wonder we all had eye strain. All right, so friction makes a problem when we're trying to perceive, when we're trying to feel those structures. So next, we're going to palpate wet. So you're going to take that same alcohol that you would prep a site with, And by the way, if you're using iodine or whatever for your procedure, or chlorhexidine gluconate, that's fine. But for this palpation purpose, use routine 70% isopropyl alcohol. Now, the alcohol that's in your typical wipe, hang on. Your typical wipe isn't wet enough. So you either need to get Becton Dickinson's wipe, and I don't work for that company. I don't have a contract. They offered me a contract. I declined it. I don't have any financial or any other connection with them, so I'm not promoting them. They have the best wipe in the world on the market for this because it is the wettest. Let's see if I can demonstrate that.
So you just buy them from that company, Becton Dixon?
No, you get them from Walmart, Walgreens.
Oh, Walmart. Okay.
Walmart's the cheapest. Walgreens is like 50 cents to 75 cents more a box, but no Walmart.
Okay.
It's great. But see how much alcohol, did you notice that?
Mm-hmm.
Is in there. They're saturated. All right. So if you don't have those, then get yourself an alcohol dispenser and cotton balls. But the
Okay.
point is, after you prep your site, your antecubital region, and we're gonna prep the entire region. Haven't talked about that here. That'll become when it's needle insertion, because everybody's cleaning the size of a cotton ball, an area the size of a cotton ball. It's a surgical field, so clean the entire antecubital region. But you leave that whole region wet, because now we're going to palpate. We're going to glide
You want another one?
palpate first from one side to the other. And we're always going to start with that antecubital line, because literally 80% of the veins we're going to locate are sitting right there. And 80% of them are sitting, 80 to 90%, and they're sitting so close to the surface you can feel them by gliding. 10% we'll have to press a little firmer and press palpate our way across to locate. We're going to come to that shortly. All right, so we're going to use our pad of our dominant hand index finger, and we're going to do it with alcohol, and we're going to be feeling for long, skinny water balloons. So that's the story. The pad, the alcohol, feeling for water balloons in that patient's arm, in that antecubital region. So that's how to locate a vein. And we're either going to glide palpate or press palpate. And again, we'll come back to that shortly when I talk about grading the veins. But this is part one. This is how to locate them. No tourniquet on. Okay, we're going to come to that shortly, but no tourniquet on for this. Not necessary. All right, so the next one, oh, this is the palpation video. Let's watch it real quick. It's short. It's only, I don't know, 50 seconds long, I think. You're ready. So we want a vein that's not only visible to see, but actually raised up off of the arm. We're prepping the entire AC region. We glide palpate and experience what feels like a water balloon bounce. And the fingers must be nice and relaxed, because if you've got a fist, then you're poking again and you're pressing too hard. There we go. All right. Now that we've located it, let's dilate this vein. They, again, remember, dilate using the tourniquet. We're not. We're going to do a true dilatation of that vein. We're going to use the vein's own anatomy and physiology to do this. So here's how that works. There are three anatomical facts we need to consider: the lumen, wall thickness, and the innervation. And by the way, let's just go back to this one. The lumen of the vein is very large compared to the lumen of the artery. And by the way, artery lumens are always perfectly circular, and they're very small, and there's a physiological reason for that. I'm not going to talk about that here. But the vein always has a big lumen. And again, if you'll think of that water balloon, that's exactly what the vein looks like. And I've got a dissection of the antecubital region on here. You'll see it shortly. Wall thickness. The vein wall is very thin, identical to that long, skinny water balloon. Everybody has this perception that the artery walls are thick, and part of the problem with that is the vein blocks of today. You can see how thick that is. Well, that's not That's not vein wall thickness, that's artery wall thickness. So nurses have this perception that this vein wall is very thick and just can tolerate anything. And it's not, it's very thin. Next is the innervation of the wall. Even though we're taught that in nursing school, nobody ever takes that piece of information and applies it to what we're doing. But there are nerve endings, and the same nerve endings that are in your skin are in the vein. And your skin can feel hot, cold, touch, and pain. So can the vein. And we react to hot, cold, touch, and pain. So does the vein. We're going to come to that, I think, shortly, but let's do this. So the big lumen with that thin wall makes that vein identical to the long, skinny water balloon. I can't say that enough. Here is the real vein. I've dissected this many times at SLU. Did my own dissections. I did the graduate program in anatomy at St. Louis University, and the vein, I should have put the artery on here because it's an impressive diagram too, but it's a very, maybe before we're done, I can pull it up from my files. It's a very thick walled structure that I had to dig deep and then pull up and expose because it's beneath muscle. Okay. So back to this innervation story. Because it has nerve endings, it reacts to everything that we do to it. So if you smack it, you're causing pain. It's going to constrict, not dilate. If you put something cold on it, it's going to constrict. We're not going to use heat because we don't have time to heat anything up, and we don't know how hot it is, and we don't want to burn anybody, and I don't need the entire arm hyperemic and red. I want one little segment of vein to dilate. So we're going to use gentle touch to do that. Well, gee, it's the same gentle touch we were doing when we located the vein. So it's so nice because you've wet it, you've glided, you've located it. Now all you do is continue to press, palpate for 7 to 15 seconds. And that vein dilates beneath your very finger. And it dilates to the size nature intended for it to dilate to. And that's going to be really important because the vein has a blood pressure. It's only 10 to 20 millimeters mercury. Think about that. The pressure in the artery is 80 to 120, 120 over 80. So the vein only has a blood pressure of 10 to 20. And if you force that over distension with too much blood, the blood pressure goes up and the leakage begins. And you've disturbed the wall of that vein. You've torn the muscle, the smooth muscle media, and you've overstretched the nerve endings, causing all kinds of pain. So we want to maintain normal vein anatomy and physiology, normal structure and function when we do these venipunctures. And not only that, if it's over distended and thin walled, what's going to happen when you poke it with a needle? Vein rupture upon venipuncture. If it
It's gonna blow. Yeah, it's gonna blow.
Right. Now, sidebar here. Varicose veins, they're not just in the backs of old ladies' legs. They can be in the arm and the antecubital region as well. So when you get weightlifters or construction guys and you see these huge ropes, don't assume they're healthy. And we're going to come to healthy in a minute when we grade the vein. But varicose veins have been forced in an overdistension, and now the muscle's torn and it won't go back. And that's why they look frilly like that. And they're very thin-walled and they're very mushy. We don't want to stick those. What you would do if you have a varicose vein in the antecubital region, just palpate up on the vein till it feels normal again, or palpate down. And that's where you would do the needle insertion. So here's the physiology. Veins do have a blood pressure, 10 to 20. Nobody ever teaches us that in nursing school, ever. And we must maintain that pressure so we don't get Starling's disequilibrium, the leakage. So back again, avoid the leakage by maintaining normal vein structure. So it's extremely important to maintain it. Then we don't cause any pain either, because now we've got a brain thing going on. Because the minute you put a tourniquet on, number one, that scares them. And so frightened people who vasoconstrict easily, now you've got an issue. But the tourniquet's causing pain, and pain causes constriction. When you poke them, it causes constriction. When you smack them, it causes constriction. So you can see all those things that they're doing is causing a brain thing. The brain is now in conflict. The patient wants to run. Kids will try. That's why they fight you tooth and nail. Adults overcome that fear and sit there, not happy, but they sit there. So to avoid all of that insanity, we're going to do gentle, gentle, gentle. So let's see what this next part is. And that's why I designed something called the Veni cuff. And it is gentle. The Veni cuff is essentially a water wing. And the tubing and cuff are identical to a blood pressure system, except for I've attached, as you can see on there, a little piece comes off, and it's a pressure relief valve. So it only allows this cuff to inflate to 20. It matches the internal pressure of the vein. So for those patients who might tend to vasoconstrict, this will keep it open. But we won't force an overdistension. So not every patient needs external support, but you won't necessarily know which ones do. So put this on every patient. For those who don't need it, there's no pain. Those who do need it will have the external support. And by the way, in pediatrics, kids know what a water wing is, and all you have to do is have one in the same room and say, you know what a water wing feels like? And they go, yeah. You go, well, that's what I'm going to put on you. And then we don't have any of that fighting and hysteria and pain and any vein issues that are the consequence of the tourniquet. So the tourniquet distorts, the Veni cuff supports. And we don't have any of those CCIFs with the Veni cuff. And there it is on an adult. Easy to
Okay, so question with the Veni cuff. What is the research on how veins work with the Veni cuff? I mean, we know about the tourniquets, but what's the research on the Veni cuff?
Okay, are you looking for patient research or are you looking for scientific research?
I guess what I'm asking is, we know the tourniquet is bad,
Right.
but the Veni cuff is lighter, so it only
It's
goes to what, 15 or 10
20
for pressure? 20 for pressure.
millimeters.
Okay, 20 millimeters for pressure. Okay, so with that being said, what is the research on any type of CCS with that?
Okay, patients experience, they love it. After
Of
they've had
course,
it,
because
they
it's
go,
not a
they go, oh my,
tourniquet anymore.
well, they go, oh my
Yeah.
gosh, I'm never letting anybody put a tourniquet on me again. Because
Yeah.
technically, you can put that needle in a vein without a tourniquet on now, right?
Okay. Yeah.
Yeah, you don't have to have a tourniquet to put a needle in a vein. Keep in mind, the only reason they're putting a tourniquet on is to force an overdistension so they can find the vein. Has nothing to do with
Right.
needle insertion. Because
Exactly.
immediately with IVs, you release the tourniquet, right?
Correct.
You don't need to maintain an overdistended vein for an IV. And with blood draw, they are instructed to immediately release the tourniquet as soon as they see blood in the first tube. And that's because when it's infiltrating, the blood left behind is concentrating and values are going up. So did they ever teach you that in phlebotomy, that immediately release the tourniquet as soon as you see blood in the first tube?
Yes.
Okay. So we don't really need that tourniquet to draw blood or to do an IV.
And actually, in practice, a lot of times you release, especially with a fragile older person, I release the tourniquet as soon as I'm in.
Yeah, but you need to anyway because of that leakage issue. I'm going to come back to that and tell you how it well, hang on here. We're at 77. Let's go back to that just real quick and make this point. All right, look at this last part over here, far right on this diagram. As fluid is leaking out, the concentration of the cholesterol, glucose, potassium, even the WBC count of those ingredients still in the system are falsely elevating. And that word is called hemoconcentration. And that
Okay.
happens instantly. And that's why the split second you put that tourniquet on, hemoconcentration is occurring. And that's why
Mm.
as soon as you see blood in the first tube, you're supposed to release that tourniquet. Now,
Mm-hmm.
blood you collected in that first tube is still falsely elevated to some degree. Question is, how much? How long? Well, it depends on how long that tourniquet was on before somebody finally found the vein and put a needle in. Because the longer that tourniquet is on, the more leakage that's occurring, the higher those concentrations are going. So you see the cascade event, the cascade of
Wow.
insanity.
Yeah.
Yeah.
Oh, okay. So when we're in the lab, when it goes to the lab, we get a lot of those values are hemolyzed.
Hemolyzed. Yeah,
Yeah.
hemolysis.
So that comes from that tourniquet.
No, hemoconcentration comes from the tourniquet. I will
But
tell you,
doesn't that affect the
nope,
blood that we actually
nope.
draw?
I will tell you
Okay.
how hemolysis occurs, but it's not from the tourniquet, and that's a
Okay.
misconception. Yeah,
Okay.
and you'll be able to put all these terms. You can put tourniquet and hemolysis into a search engine and it won't pull up any research. Well, I don't know what kind of research you'll put, but it won't tell you that it does that. Hemolysis
Okay.
occurs for another reason altogether. Actually, there are 5, but we're going to cover that a little bit later. I wish we could do it all in one day because you've got good questions. All right, so let's go back to this. Now, research-wise, as far as, because I can't tell you how many medical nursing schools will go, well, where's your research? And I'm like, okay, well, this is brand new. So guess what? I'm it.
Okay.
Now,
Okay.
I'm not completely it because here's why. In order to use that VeneCuff, I had to go through FDA, Food and Drug
I'm
Administration.
sure. Yeah.
Okay. All right. So the beauty of that for me is somebody's already done the research and they created what's called it's not precedent. I'm trying to remember that legal term for trademarks and for patents. But a precedent has already been set because somebody already did the research on the cuff. Their cuffs inflate to 200. As long as mine's below 200, I fall under the guidelines of FDA. The tubing
Okay.
and the bulb are already approved. The pressure relief valve controls the amount of pressure, so it's an already approved. So the entire VeneCuff is FDA approved.
Okay.
All right. Okay, now, oddly enough, you would think that tourniquet would be, and nobody's FDA approved the tourniquet, and they allow anybody to put a tourniquet on, and they allow any amount of pressure on that tourniquet, right? Some people do light, some people strangle the arm until it's turned blue. So no regulation on the tourniquet. All right, so
Mm-hmm.
back to VeneCuff. So it prevents overdistension and supports the vein. Now, all right, so in the meantime, it says here, if you're going to apply the tourniquet, if you're going to continue to use that tourniquet, it can only be snug, not tight. And snug means 20 millimeters mercury pressure. And you're going to go, well, how much is that?
Yeah.
What's the problem?
Right. You
It's
can't.
plus.
Yeah. You can't measure it.
Right, it's a guess. And anything over 20 causes leakage. So the tourniquet the VeneCuff needs to be. Okay, so next. Now we want to grade the vein. So we located it and we dilated it without a tourniquet. Now let's grade it. Because I call it, we want a healthy vein, one that's going to tolerate the stick and the procedure, not one that ruptures upon venipuncture, and not one that has the potential to leak, even if it doesn't rupture.
Correct.
Well, the same method for locating and dilating is what we're going to use for grading. It's going to be gentle touch. So the gentle touch palpation technique. Now, here's what you need to know. Not all veins are created equal. First off, hand veins, and we're going to come to a diagram shortly, but veins are the thinnest walled veins we have in our body. The inferior vena cava and superior vena cava from the heart are the thickest walled veins we have in our body. And it has to do with the pressure in the vein. because the closer you get to the heart, the higher the venous pressure is. The furthest away from the heart, the lowest the venous pressure is, okay? But not all veins are created equal also because of health, whether it's a varicose vein or it's a vein that's still intact. Now, we're going to grade this vein for 4 characteristics: firmness, size, direction, and depth. Firmness is the most important. And firmness refers to wall thickness. But before we get to that, let me state this. When you look at a vein, you can't tell anything other than, oh yeah, there's something blue sitting there, right? And in fact, that expression, you can't judge a book by its cover. Well, you can't judge a vein by its either, because appearances are deceiving.
They are.
And how does the blind man read? He feels.
By touch.
All right, so that's what we're going to do, and we're going to select a healthy vein. So firmness describes wall thickness. Size describes the size of the lumen of the vein. Direction is knowing for a good full inch what direction the vein is going, especially when you're placing IVs. And then depth, how deep are these veins? Because they come in 3, superficial veins come in 3 depths. So we're going to cover all this. Let's take a look. If we go past an hour, do you mind?
No, it's fine.
Good. Hopefully we won't. All right. So 2 types of veins in the body. We know that: superficial and deep. Deep are always beneath muscle. Okay. Shouldn't access those, because when you do, you can create a deep vein thrombosis by creating a clot there, and that becomes the pulmonary embolus. So we're always dealing with superficial veins. Next. Firmness then is wall thickness. Now, here's the perfect example. By the way, the bouncy balloon is the wall thickness of the inferior vena cava and superior vena cava. So if you can imagine that, how thick that wall is. But in between the hand and the antecubital region, here are wall thicknesses. The hand has a wall thickness of 1 layer of that glove, literally. And I call that, on a scale of 0 to 10, has a wall thickness of 2. The tourniquet, the typical tourniquet, has a wall thickness of about 6 to 7. And the rule is, if it's 5 or thicker, you can stick it. It'll tolerate the needle stick. If it's less than 5, do not. If it doesn't rupture, it will leak. How many times have you seen IVs in the hand, even though they tolerated the stick and they appear to be intact, they're infiltrating? It's because the vein wall, venule wall, and venous part of the capillary bed are too thin. Okay. So firmness in the antecubital region. And when you get a human and you start feeling those, it's just totally amazed, because you're going to go, wow, that wall does feel much. And it's usually a 7 to a 10. In the hand, again, it's 0 to 2, 1 to 2 for wall thickness. Every human, even in a child, they're thin. And in the wrist, and here's the interesting part, on the wrist, at a particular point, it goes from a 4, a less than 5, to a 6 or 7 instantly on every human. But it's not, you have to determine where that transition occurs. It's not the same on every human. So when you feel it, you have to always go above the part where you find the 7, not below, or you'll end up with an IV infiltrate. Okay, next. Again, we're thinking of the long, skinny water balloon. You guys have dollar stores out there, I'm sure, in California. And if you've ever bought water balloons to make animal balloons from a dollar store, it won't work. They rupture. That's because it's a cheap balloon, very thin wall. But if you go to the craft store and buy a water balloon for animal balloons, it tolerates the distension because the wall is thicker. So I actually, in my office here, have samples of, show you. I actually created the cheap and the more expensive balloon and let them actually feel. And you can really feel the difference. Okay, next. So again, the rule is, and here's what's interesting, Gray's Anatomy tells us that some of the most peripheral, the most distal veins in the hand are missing that middle layer of muscle. So you're just dealing with two thin layers of just tissue, connective tissue. You don't even have any muscle for substance. And then of course the varicose vein rule, they feel very thin walled. All right, so visualizing that vein won't tell you anything about wall thickness. You have to feel it. Next, then that's why vein wall thickness is the most important criteria of all the criteria that we deal with. Because if the wall is not thick enough, it doesn't matter how big and how beautiful and how blue that vein is, you cannot stick it. Now I'll show you, shoot. Oh, here we go. I'm going to try and create a varicosity. So when you've got a vein in a closed system, which it is in our body, and you put a tourniquet on, that's a varicosity. Only in a human, the muscle gets destroyed and it won't go back. It stays distended, injured. All right. Next, size. It's not even about target practice. You want a good vein so you can see it, so you can stick it. Size for us is how big the lumen of the vein is, because we're going to pick a particular size needle to put in that lumen. And here's the problem with their forced over distension of the vein, okay? Well, what size is the vein, really? What size needle goes in there? Well, they don't know. So if you pick a vein that's already small, you've forced a distension, and now you've come up with a needle that occupies the entire lumen, you're in, but you're not going to get anything out for a blood draw because your vacuum's going to suck the wall in and cork it off. And with IVs, there's no backflow of blood going with your IV fluids that you're trying to infuse. So we need to determine the size of the vein first, then pick the appropriate size needle for whatever venipuncture procedure we're about to do. And there it is. Okay. And that's the question then. What's the true size of the vein or its lumen? You won't know if you have over distended it. So one more scientific reason why we need to maintain the integrity of the vein and the vein wall. Obviously, I harp on this one a lot. All right, next is the direction the vein is running. Did I lose you? No, you're still there. Are you still there?
Yeah, I'm still here.
Okay, good. I thought for a minute I lost you. All right, so the direction the vein is running. You need to know that because if you come in at a diagonal or a cross-sectional, then you don't have a lot of lumen to work with. And obviously, if you're trying to place that IV cannula, you're going to have an issue. So we need to palpate at least, and you feel that. With the pad of your finger, you're going to feel about an inch of vein wall. And you'll be able to feel the entire length of it with that pad. And then you mark it so you know exactly what direction that vein is going, and you line your needle up with it. All right. And with the balloon, you can do that. I always tell people, you know, you come in and you feel at a cross section what it is, yeah, but you need to move the finger around until you're in alignment with it. All right, so for depth, we're always dealing with superficial veins. That's a given. Okay. And when I say superficial, I always tell my new students who aren't used to all of this that think of the S, superficial, surface sitting beneath the skin in the subcutaneous tissue, all those S's. If you access a deep vein, you run the risk of DVTs and then PEs, and those can kill the patient. So superficial veins come in 3 depths, and I have the beautiful example of that with my arm. I don't know if you can actually see that vein there, and it's huge, and it sits.
Yeah, I can see it.
Good, it sits on the surface and it's blue. So it's a shallow superficial vein. Now I still need to grade it to make sure the wall is thick enough to tolerate that stick, and that one is. So, but shallow superficial veins, healthy ones, only 10% of all these blue things that we can see are healthy, stickable for venipuncture. I mean, and that's amazing. But when you start palpating those veins out there, you're going to go, oh yeah, I get it. Now I see why these veins in the hand and the wrist are constantly failing, especially the hand veins. Average depth, this one. On my arm, you can't see it, but when you glide, palpate, you can feel that rubber water balloon just sitting right up there, no problem. 80% of the veins you and I are going to stick as a healthy vein is in that group. So that's why 90% of what we're going to stick, we can feel by gliding. They're easy to locate. Deep with a little d because deep with a capital B or D are the ones we're never going to stick because of DVTs and PEs. But deep with a little d, they're slightly deeper in the subcutaneous tissue. We have to press palpate our way across the region to locate those. Now, between now and the next one, should you decide to continue with this virtual, I'm going to send you a couple of vein blocks in the mail. So I can do more with this palpation technique to further demonstrate the distinction between all of those. But shallow, average, depth, and deep. And again, average and deep, you would not be able to see. Now, with a vein finder tool, you can see half of the average depth ones. But once it reaches a point halfway across that bell curve there, and it's going deeper into the tissue, the ultrasound and the vein finders won't penetrate that deep. They're not designed to. And that's why those tools are useless. And you can't see veins, no matter what veins you're looking at, on dark-skinned people. Well, there went half of the world, right? So it's really a useless tool. Now, I always say those people who need to see to believe, they're in trouble on so many levels, not just on venipuncture. But with our finger, a blind man can locate veins. We do want to look when we stick. But a blind man can actually locate veins. So can we. Now, I actually ended up moving that. Sorry. There we go. Let's look at this next one. So healthy superficial veins come in the 3 depths. 10%, those we glide palpate, you can feel and see blue. At 80%, you can still glide palpate to locate. You can't see the blue, but you can certainly easily feel the structure. And deep with a little d, we're going to have to press palpate our way across. Now, so vein site selection then is going to depend on primarily you, but also too the veins in the patient's arms. But typically antecubital veins obviously are ideal for blood draws, and plasma and blood donation and injection of contrast. And then short-term IVs, that's where they should be put. So you're out there doing mobile and it's short-term. I would be putting them in the AC region. They can sit for a couple of hours, no issue. If you're doing long-term and you want them up and moving, then you want to go to the wrist. So wrist or long-term IVs are a secondary site listed for the above. But never, never stick the hand. In the wrist, by the way, and I didn't do that here, and I'll send that to you. We'll do it on the next one. Hand is always in the handshake position, and the vein we want is on the surface here. And unfortunately, one of the local hospitals ruined my cephalic vein. It's gone. I'll have to send you pictures of my identical twin to show you how full they used to be. They were twice that size, twice the vein size in the hand sitting on that wrist, but they're both gone. They ruined both wrists on a hospital stay. So it's possible to permanently damage these superficial veins. And now you've got people wanting to put PICC lines in because they can't find anything superficial. We need to avoid that.
Now, my question is, and I know we'll get into it later. My mom, she's like the prime example of a terrible stick. She's very dark skinned, can't see a vein, and you totally can't feel a vein. And her arm is a little bit edematous. So when she goes to the hospital, it is always terrible because they're sticking her multiple times. Her veins blow, so the medication doesn't get into the vein,
Right.
and they always have to start a PIC line on her or an central line.
Yeah.
So
And
those
that's that.
people that are those chronically bad sticks because their veins are small and weak, how do we use this technique for those particular patients is what I really want to get to, because I deal with a lot of elderly.
Okay.
I
Well,
deal with young patients too.
here's this
I
here.
have about a 50-50. So I deal with young patients that are healthy that I don't have that problem with.
Yeah.
But I also find, a lot of those patients, probably about 25% of my clients are older with bad veins and you can't feel them, or they're young and you just can't see them or feel them because they're deep and small.
I promise you, Corey, with this new technique of palpating wet, 95% of the time you're going to feel veins on all those patients, no problems. You're coming from the nursing culture where they told you, oh, there are just difficult sticks out there, and some of these veins are just so small that blah, blah, blah. And it is blah, blah, blah. So the only thing I can say to you is try this. And when you do, and you're going to go, oh my gosh, I can feel a vein when you couldn't before. You are going to be impressed with this technique and convinced this is the way to do it. So the first one to start with is your mom. Get the alcohol,
Okay.
put her arm in a 45-degree bend and make sure the palm is palm up, not side.
Mm-hmm.
To put those vessels in the proper position, it must be palm up. And then
Correct.
palpate, and you're going to be shocked. It's going to be like, oh my gosh, I found a vein. And of course, the more you do and the more confident you become at it, the easier it is to locate them. But no, I've been doing this now for almost 40 years. And literally this technique, I mean, I literally have a 99% success rate on sticks for IVs.
Okay.
And it's because if you know where the vein is at and you pick
Yep,
a
you can
healthy
stick it.
one, yeah, chances of it going awry are slim to none. So truly improves it.
Okay, so yeah, as we get into it, when I start using the not the tourniquet, but the cuff.
Yeah.
Yeah.
Now
Okay.
here, I just have 2 more slides. So the
Okay.
summary is palpate to locate, to dilate, and to grade. And here's what I want to remind you. The vein only has a blood pressure of 10 to 20. So how much pressure can you put with your finger in that vein?
Very, very little.
That's
Yeah.
right. So get yourself a long, skinny water balloon. Maybe I can send you some. And fill it so that it's not distended at all. It's just got water in it. And when you press palpate, you'll realize how gentle it has to be, because if you put any pressure at all, you're going to pop right through it and feel the table. Now you know, too much pressure there. So the external pressure must match the internal pressure of the vein. And then one last slide, now that you've been through all of this. So what's the pressure of the blood in the artery? 120/80. What's the pressure of the blood in the vein? 10 to 20.
20.
And what's the pressure of the tourniquet? Who knows?
We don't know.
Individual. Yeah. And so what effect does the tourniquet have on arterial blood flow? It cuts off arterial blood flow. Well, we need arterial blood to make venous blood. And that's why their arm turns blue if you don't. And what effect does that have on Starling's equilibrium? I just showed you. It forces an overdistension, it leaks, and you get a falsely elevated lab values. And then what is Starling's equilibrium? You now know the story. So what's interesting is if you were to take that slide and ask 20 other nurses, hey, what's Starling's equilibrium? They'll give you pressures of the heart. You go, no, not of the heart, of the venous system. They go, I don't know, never heard of it. Nursing didn't teach us this, and it's critical. So there's my 1 hour. Did you feel like it was worth it?
Absolutely. Yeah, I am definitely interested in so how much does the cuff cost?
Well, the cuff is 35.
Okay. That's
Yeah.
the one that was on that's the one on your website for
Yes.
35 to buck. Okay.
Yes. But if you're gonna do more virtuals with me, if you'll do the rest of the series with me, I'll throw the cuff in free.
Oh, okay, thanks. Yeah,
Yeah,
I'm gonna do the rest because I want to make my patient experience better and I want to get a higher ratio of,
of
starting the
success.
IV than not starting. Yeah,
Yeah.
I want a higher
Well, yeah,
success rate. So
because I can tell you how to avoid those infiltrates and that hemolysis story. I mean, you really need to hear this whole thing. So not only will it be enlightening and helpful, but down the road, as you can see these slides, I mean, if you decide you want to teach this down the road, PowerPoints
hmm
are already set up, and you will have had, I should have told you in the beginning too, you were free to record this. I'm recording it, I think, so I'll be happy to send you a copy of it. But you'll be able to teach this to other nurses. So, and phlebotomists for that matter too.
So when you're teaching it, you got to what are you getting like the dean of the college to agree to it?
Yeah, see, I don't even go to the colleges yet. No, those people are
Okay.
still so far in the dark ages. I don't
They
expect them to
are.
come on board for another 10 years, literally. No, what I
Yeah.
do is, it's interesting. You actually just put the word out there and you can tell, you can go actually to nursing homes and tell CNAs, hey, level up, learn this phlebotomy skill. And most of them don't want to be a CNA anymore. So a lot of them will come. Nurses, if you just put the ad out there, I don't know if I already sent you my updated ad that I just put out, but I will.
What I'm probably looking to do with this particular block of instruction would be I have some people that I know in some different groups that are actually teaching phlebotomy. I would offer the program to them
Yes,
for cost so that
yes,
they could teach their people how
yep.
to do it. And then that way, it could be cost effective.
That's what I'm going to do around here is go to the local phlebotomy schools. You can't go to
Yeah.
colleges, the nursing programs, they won't listen. But the phlebotomy
Okay.
programs might. And if they do,
Well, nurses don't even really teach you how to do it in nursing
no,
school. Honestly,
no,
you learn that on the job
on
because
the
they say
job.
not all nurses are going to be doing this, so they don't really teach you. When I
Yeah,
went to nursing school in '05, they didn't teach me how to do any
no,
of this. I learned as a phlebotomist when I went to the military. I
yeah,
learned I learned how to do this stuff, but
yeah.
we didn't learn this in nursing school. We learned it on the job.
Right. There isn't a
So that's
nursing
what
school who teaches it.
that's why it's so haphazard because
Yeah.
it's all up to the facility who is overworked with short staff to teach a
Yep.
process that that's they're just given a little 5-minute training to.
When I tell professionals in the medical
Hmm.
profession, so PhDs and doctors, whatever, that nurses are self-taught, trial and error, they go, oh, no,
Hmm.
that can't be. And it's like, yeah, that is the way it is. Self-taught. Well,
Absolutely.
this was fun. I'm glad you enjoyed it.
I did.
I'll send you some information when we get off here, and then let me know when you want to do the next session, and I'll set it up.
Okay. Okay. Just send me some dates and we'll
Okay.
reevaluate and get our dates together so we can do it again.
Do you want me to give you dates for
Um,
next week, or do you want me to wait until the first week of January?
that's up to you.
Okay, well, no, I'm
If
free
I
next
did,
week.
if I did it, it'll probably be another Saturday. So
Okay, wonderful.
a
I'm gonna
Friday.
be
I'm usually open on Fridays and Saturdays, so
great.
those
That'll
are good
work.
days for me. Yeah, those are
That'll
good
work.
days for me.
All right.
So whenever you have the availability, another weekend,
All right.
whenever. It's not imperative that we do it next week because I know next week is the first of the year. So
Oh, I don't, I don't go out and celebrate anymore. So Saturday works for me, but I'll send it. I'll send a couple of Saturdays and you pick whichever one you want.
okay, sounds amazing. Thank you
All right.
so much for the training.
Yeah,
This is very amazing. Um, and I can't wait to use the tourniquet. I mean the
the
puncture
beanie
cuff.
cuff. Yeah.
That's gonna be life changing for my practice because I do quite a few lab draws and I have a couple of patients that are really difficult sticks. So this will be life changing for them because I won't have to stick them and it won't hurt.
Oh, and I do
'Cause
want
I'm
to
not-
tell you, yeah, it's going to improve. I do want to tell you this. This part one of locating, dilating, and grading is part one of it. You know where the veins at, it's a healthy one. But the other part, which is just as critical, is the new needle insertion technique. And believe me, I haven't changed it. Science changed it too. So you're
Yeah,
gonna
because you
be,
were saying instead of doing it a 15 to
yes,
20,
it's gonna be
you're going to go
45.
at a 45-degree
Yeah.
angle.
And you're gonna be so surprised at the science behind it that supports it. And your patients are just gonna go, my God, best blood draw or best IV I've ever had. You're gonna hear that.
Yeah, and that's going to be amazing because I'm getting ready to start working with the doctor and my nurse practitioner doing IV hydration.
Yeah.
So this is going to be life changing because I'll be doing lots of a high volume of patients for IVs, not just the blood draws, but IV
Yeah,
sticks
the
too.
IVs. Well, what's great is
Yeah.
when those patients come back and say, gosh, doc, that was the best experience I ever had. They will come back. Number one, you'll get a repeat session. And number two, they'll go out and tell their friends. And I always tell
Exactly.
people the converse is true, like with blood donation. If it's a bad blood draw, bad blood donation, they will never be back.
And they'll never forget it.
Yeah, we want people to return. We want a good experience and we want them to return. Well, Merry Christmas to you and the dog, and if
Thank you.
the family, and let me know how this works.
I sure will. Thank you. We'll talk soon.
All right, bye, Toy.
Bye-bye.